Conference will now be
individuals
recorded.
coming in because I guess DDS is going to start requiring regular
Okay,
trainings and so forth. So
all
we're
right,
hoping to get a little bit more coming soon.
cool. All right, so let's go ahead and get started then. Let's get this going. The This course is eligible for 1.5 hours of continuing education credit for both Kern Regional Center uh, for DSPs and also through community care licensing. So if you are a licensed residential facility or work for a licensed adult day center, you can get the 1.5 hour credit. So you actually get credit for both, which is kind of nice. But there are some rules. We live in a system that has lots of rules. So you must attend the entire webinar um, to get the CEUs. You must identify yourself. So I see everybody's got their name on the screen, which is good. Once in a while, we will get somebody who doesn't put a name on there, and so we don't know who you are. Um, if there's more than one person from your location who is on today, we need to have all of the names. So anybody who wants to get credit needs to put their name either on the screen or they can put it into the chat. And Irene, who is the coordinator of this project, will be keeping an eye out periodically as I share things with you today. She may put a comment or an email address or a link in the chat. So kind of keep an eye on the chat. And if you have other people in attendance, please make sure that they get the credit as well. What you need to do is at the end of this, on my copy, it doesn't show up very well. So Irene, if you could put up, Valerie, if you could put Irene's address in the chat, I'd appreciate that. In adult learning, if you write things down, you're more likely to remember it. So, for a combination of reasons, I would like you to come up with 3 things that you learned today from this webinar, and then send those to Irene. And that is what we're using as a way to knowing that you actually, fully attended this conference. Doesn't have to be a page or a book or anything else. Could be just 3 bullet points. I learned that when the rules related to home and community-based waiver services were first initiated and when they went into effect, etc. And that's enough. That would be one of the 3 that you needed to learn. So do write down 3 things that you learned today and send those to Irene, and then you will get your credit. We'd like you to send that to Irene within the next 30 days because we like to kind of stay current on this. We want to make sure you get your credits. We've had in the past people who all of a sudden, are calling us up frantically. Hey, I took that class 8 months ago, and now licensing's here, and I got to show them proof that I took the class, and I don't have anything to show that. So please don't wait. Please get it in promptly, and that way we can get you your certificate promptly, and it works best for everybody. Okay. Email from yesterday and this was from the Department of Developmental Services, just a little bit of updated news. Vendors, and it was addressed to vendors and applicants. Get ready for a standardized vendor process. The Department of Developmental Services, the state agency that gets the money, that then gives it out to the regional center, that creates the rules, that monitors the system, is now looking to make it so that if somebody wants to become a vendor of the regional center, there's a standard process. Right now, there are 21 regional centers, 21 different ways of vendorizing. State says, no, we want to make sure that everybody meets the same standards, and there's a way that all vendors are approved for the system. So on January 2nd, they're going to be having a webinar on their website that will be specific to the new changes. DDS is pleased to announce that soon all regional centers will begin using standard vendorization process through the provider directory. So if you're familiar with the provider directory that the department's been working on for some time, that will be the format by which they will be doing vendorization. And what they're going to be talking about in that webinar next month is why the process to become a service provider is changing. They want to standardize it, make sure that everybody's using the same criteria, basically. What is changing for potential and existing providers? So if you are existing provider, your vendor, there may be some changes coming down the pike as well. And what is the impact to potential and existing providers? So they'll talk about what the changes mean. And finally, when will the changes apply to me? So if you're interested at all in seeing the latest in vendorization, that will be coming on December 2nd. Okay.
Jeff, there's a few with their mic on. You might want to shut it off because I hear a little bit of interference while you're talking.
Yeah, okay, let me see if I can do that right now. Okay. I got them turned off. Thank you for letting me know. This was one of the headlines on the front page of the LA Times on Saturday. Residents were left behind at senior facilities as Eaton fire rage. State finds serious lapse. What this article talked about was that when they had the large fires down in Los Angeles last January, the one that occurred in Altadena near Pasadena there were two residential facilities that didn't evacuate all of their residents when the initial warning went out to evacuate their facility. Fortunately, the two residents in one facility and the one resident in another facility were gotten out, because by the time they realized what had happened, the emergency personnel, but in one case, fire personnel had to go into a building that was just catching on fire, was just starting to burn, and get the people out. So licensing has cited the facilities. State investigators cited two senior facilities for leaving behind residents during the fire. And the state investigators cited both facilities for troubling lapses in care and ordered the homes to increase their emergency planning and training. Now, in both cases, the facilities are appealing the site that they received from licensing. And so this is an ongoing story. But one of the things that they talked about in the article was that, it happened at night, and some of the staff that were on weren't aware of the emergency plans for the facility. So what are the emergency evacuation plans? What are the stay in place plans? What do you do under different situations? Now, in most cases here in Kern County, unless you happen to be residing in like the mountains around Lake Isabella, Kern Valley, fire is not necessarily the issue. But we do have other types of evacuation situations which may occur for us. Earthquake is a very likely occurrence in our areas. And if you have a large earthquake and your facility is damaged, your utilities are shut off, there is some sort of a problem that you need to relocate the individuals that you serve who are in either your day program or in your residential facility. How would you go about doing that? And do all of the people who work there know what those procedures are? So we want to make sure that if an emergency were to occur, that you'd be able to address that. Last Saturday, there was, fortunately, we didn't have much flooding, but there was some flooding that occurred, and that could have been a challenge for some homes. And if it was, how would people in that home move people out? So, in the case of these were large residential facilities for the elderly. So if you're a small family home or a small group home with 4 or 6 people, you're probably going to be able to account for all of your residents and get them to your alternative site that you have in your disaster plan. But if you're a larger program, say for example, an adult day program, how do you make sure that you account for all of the individuals that were at the site or at the, wherever they were at the time the disaster occurred, and got them to the alternative site that you have in your plan? In the case of one of these facilities down in Southern California, they put all of the sheriffs came. They brought like some emergency school buses. They loaded all the residents onto the buses, got to the emergency site, and then when they got to the emergency site and did a head count, they realized 2 of the residents hadn't been transported from the site to the alternative location, and so they didn't take a good head count. So those are the sort of things that you really need to keep in mind when you are doing emergency planning for your facility. I just noticed that there's somebody who just came on. It says caller number 1. If you want credit for this class, you need to identify yourself either on the screen or in your in the chat. So if you go ahead and do that, we would appreciate that. Okay, so moving on. And this is the part where I'd like it to be interactive. So if you want to open up your mic when you read the question, I'll read it out loud, and give an answer, then we can talk about why that answer is correct, or whether it's another alternative that is the correct answer. So the first question that I'm asking today is, what is the primary goal of the HCBS setting final rules? 1, increase institutional care. 2, promote person-centered planning. 3, reduce Medicaid funding. And 4, limit community integration. Anybody want to answer that one? You go ahead and open up your mic and give me an answer. All right. Well,
hi, good morning, Jeff. Can you hear me? Hi, good morning, Jeff. This is Leslie Mosqueda from KRC. Good morning.
Morning. How you doing, Leslie?
Can you hear me?
Yeah.
Okay, I'm doing great. Thank you for asking. This is a really good question. So, and a very easy one. So, like, what is the primary goal of HCBS settings final rule? So, I would say it's to promote person-centered planning. That's like the core focus around HCBS. How can we make it meet the individual's needs in the best way? It supports their rights through that avenue and overall drives their services. And so I would say it's that answer. And I hope others on this call can chime in on the next few questions.
Okay. Yeah, please do. And Leslie, you're absolutely right. Now, going through these, the first one was increased institutional care. It is just the opposite. What the home and community-based waiver services were is to try to do services in people's homes and in their community. Institutional settings tend to be outside of the community. So when we think of institutions, we oftentimes think of Porterville or Atascadero or Camarillo or Stockton or Agnew's, or there were a number of them over the years. Many of them have closed, and so in California has closed all of its large institutional settings, and home and community-based waiver was one of the impetus behind that. Reducing Medicaid funding, that's not been a goal of the home and community-based waiver. The home and community-based waiver clearly says that the cost of providing home and community services shall be no more than what it costs for institutional care. And in California, as we got close to closing the last few remaining large facilities, they were originally called state hospitals, and over the years they changed the names to developmental centers. So as we got close to closing those, the cost of each resident living there continued to get larger and larger, because you had costs like for the grounds, to maintain the facility, the heating and cooling, the cost of the staff, all that stuff. So when you divided that over the number of residents you had, it got up to where it was over $300,000 a year per resident. Now, rarely have I ever seen anyone living in the community receiving community services that cost that sort of money. So there really isn't necessarily a reduction in Medicaid funding. That Medicaid funded the institutions too. So if anything, home and community-based waiver has lessened the cost. One of the challenges that will be occurring in the near future is that recently the U.S. Congress passed a budget bill, which is referred to as a big, beautiful bill, that over the next 10 years reduces Medicaid funding, in California it's called Medi-Cal, by $1 trillion. And so that is going to reduce the amount of money available for services. Home and community-based waiver services are an optional services. States can decide whether they want to provide these services and what services they want to provide. So California has a list of services that they've submitted to the federal government, this list, and the feds have taken a look at it. They've decided which ones that they fall under home and community-based services, and then they've granted California the ability to provide those services and receive federal dollars. And the federal government pays 50 cents on every dollar for those services. So what may happen over the next number of years, over the next 10 years, is that as the federal government provides less money to states for Medicaid funding, some states may say, well, we can't afford to be providing services to persons with developmental disabilities under home and community-based waiver. And so we're going to cut back the number of services that we provide, or cut them out altogether. For those of you who have been in the system for many years, in 2008, when we had a recession and funding got severely cut back, there were services that were to persons with developmental disabilities which were discontinued for a period of time, including dental services, because that's an optional service. But there were a number of other social recreational services. A number of other services were reduced or eliminated because they weren't required. So we may see some changes in Medicaid. We will see some changes in Medicaid over the next 10 years. And then limiting community integration, that again is not what we're trying to do. We're trying to increase people's ability to utilize the community. Okay, second question here. Hopefully we'll get a little better response this time. Which of the following is a key requirement of a complemental HCBS setting? Okay, one is it's a good setting if it's located on a hospital campus, or offers limited access to the community, ensures individuals' rights of dignity and respect. Oops, let me move this over a little bit. And respect, and then also the last one is required shared bedroom for all residents. So anybody want to answer that?
Hi, good morning. This is Edna Dizon of Willie Home.
Uh-huh.
I think that, yeah, Edna Dizon of Willie Home. I think the answer is to ensure individual rights and privacy, dignity, and respect.
Perfect. You got it. That's exactly right. Um, um, now, it can't be located on a hospital campus. The one thing that we're trying to do is get away from um, a setting that is next to an institution. And matter of fact, there's something we're going to talk about a little later. I think on one of the other slides, something called heightened scrutiny, which is where the feds require additional review of a program because it's too close to or looks too much like an institutional setting. So that one is not. And then offers limited access to the community. Again, that's what we're trying to get away from. We want people to have access to the community. That's the whole point of home and community based services. And then finally, requires shared bedrooms for all residents. We're trying, again, for those residents who have historically lived in a shared bedroom, we want to make sure that they are in agreement with who the roommate is and that they are in agreement with the type of setting that they live in. And that is an individual person's choice into where they reside. Okay, next question. And this is a true and false question. The home and community-based waiver rule applies only to residential settings. True or false? Okay, the answer to that one is false. The home and community-based waiver services apply to a number of services. The two services that we most often see it in, because they are the biggest providers of home and community-based waiver services, are residential and adult day. But there are other services that also fall under the home and community-based requirements. And if you go to the DDS, Department of Developmental Services website, which is dds.ca.gov on the internet, and click on Medicaid waiver, you can find a list of all the ones that have been approved by the federal government for California's plan. So the home and community-based waiver is more than just residential. Okay, which of these is not a characteristic of a home and community-based setting under the final rule? So one of these is wrong. Okay, integration in the greater community, choice of daily activities, locked doors for safety, and control over personal resources.
Lock doors for safety.
Locked doors
Again,
for
this is
safety?
the of the home. Lock doors for safety.
Okay,
Yeah.
that is correct. There is, and thank you for the
I got two answers already.
okay. The this can sometimes be, and the reason I put this in here, clearly we want to maintain people's safety, and as a facility owner, or especially if you're residential, or if you are day service, you don't want people just walking into your facility, off the street or whatever. So many places have security related to entrance and exit from their properties. And, as long as clients have the right to come and go, consistent with their individual plan, some people, have more ability to utilize the community independently. Some people need assistance to you, and that needs to be in everyone's plan. But, there is a requirement that in residential facilities, the residents have a lock to the door on their room so that they can have privacy in their room. So unless they choose to waive that, the assumption is that they should be able to have privacy in their own room to safeguard their own possessions, etc. So again, the other three answers: integrating in the greater community. That's what community services are all about. We want to get people out into the community. People should have choices in their daily activities, and they should have control over their personal resources, which is, you know, their money, their items. You know, if somebody has a cell phone or a you know, so their own TV or other items that are theirs personally, they should have control over those items. Okay, next question, moving along here. Oops, it's doing this. What is the role of person-centered planning in HCBS final rules? One, to standardize care plans, to ensure services reflect individual preferences and goals, to reduce providers' workload, and to limit service options. Somebody new? Anybody?
To ensure services reflect individual preferences and goals.
To ensure services reflect individual preferences and goals is the answer. So second option, okay. Somebody just put in second option. That's correct. Years ago, when I first started in the system, I was a service coordinator. Back then, it was actually, my title was psychiatric social worker. They changed the name of the job that regional center provides over the years a number of times. I went from psychiatric social worker to counselor to, and then finally the term that we use now, service coordinator. But it's no, case manager. It would be a counselor, case manager, then service coordinator. So it's at least 4 times the name of the person who provides the services has changed over the years. But we did oftentimes the old joke about a cookie cutter. You know, when you've got the dough on the cookie sheet, and you're using the cookie cutter, and you're cutting out the mold for your cookies. That's what we would oftentimes do for IPP meetings. We would have a standard goal and objective, and basically, you know, or maybe 3 or 4 of them, and everybody got one of those 3 or 4. So it wasn't all that uncommon to see something like, Jane will attend ABC day program. Jane will live in, the Smith family home. Jane will have her health and safety maintained. And those are the 3 objectives that you would see in someone's plan. And then you'd go and down the street to the next facility, and you would see the same objectives. The only difference, it would now be for George. So George would go to the ABC program. He would live in this home. He'd be maintain his health and safety. So that's what we want to get away from, is a plan that is the same for everybody. And it's not about reducing our workload. If anything, the new centered planning process has probably increased your workload. You know, the new format that Kern Regional Center is using to do person-centered planning requires them to ask a series of questions and to fill in a lot more information on the person, focusing on their strengths, their capacity, their ability, their desires, their wants, because that's what we want to do, is we want to set it up for the person. So unfortunately, we're not reducing workloads. It would be nice, but that's not what it's doing. And then we're not limiting service options. We want people to have a full array of services. So whatever services are available out there, we want that individual to be aware of what those services are, and then to make choices about which of those services they would really like to have. So one of the things that is coming down the pike, and will be interesting to see how it really works, is the Department of Developmental Services is developing the provider directory, and that directory they are saying will partially make it so that families and individuals will be able to have more choice. They'll be able to see all the services that are available out there, and then to make choices regards to that. Let's see over time if that really does make a substantial difference in terms of the ability to give people more information. And with more information, we see more choices. Okay, moving on to question 10. Which federal agency oversees implementation of the home and community-based rules? The Center for Disease Control, the Center for Medicare and Medicaid Services, the Food and Drug Administration, Health and Human Services Office of Civil Rights, or the Department of Developmental Services. Any takers on that one?
The Center for Medicare and Medicaid Services.
Yep, yeah, that's correct. We sometimes refer to them as CMS. They handle all of Medicare and Medicaid services. The new Trump-appointed director of that is the old TV personality, Dr. Oz, now runs the Medicaid and Medicare services. And they have an extensive website. So if you're ever interested, if you go to cms.gov, you can find some very, and then click on HCBS or Medicaid services. Lots of information. So if you're ever interested in more on this, you could find it there. Center for Disease Control does not have any major involvement with our services, although recently the new administration has put a focus on autism and wanting to look at what is responsible for the large increase in the number of individuals that have been diagnosed with autism, and seeing if there's something that is in the environment or in in medications or other things that might be a causal for that. Most of the research that's out there currently has looked at environmental issues as well as genetic issues as being the two primary things responsible for that. Food and Drug Administration really does not have any involvement for the most part in developmental disability services. Health and Human Services Office of Civil Rights, that has to do with if there is a civil rights complaint about services under home and community-based services, but it's not the agency that oversees home. And then the Department of Developmental Services is a state agency that oversees the regional center system. Okay, moving on. Okay, this is kind of a interesting question. By what date were states required to be in full compliance with the HCBS rules?
March 2023.
Yeah, that's a good answer. Actually, it's a little bit of a trick question. All of them are correct. The original document that was put out for home and community-based waiver was put out in March of 2014. that prior to 2014, there were a number of hearings, there were a number of published, these are the guidelines of the direction we want to go. Please give us comment. And over a period of time, they finalized the rules, and they came out in March of 2014. And the original implementation date would have been March of 2019. In 2016, when Donald Trump was elected president the first time, his director of Health and Human Services, which oversees the Center for Medicaid and Medicaid Services, CMS, said, these are very complex rules, and it's a major shift in the way we're doing services. So I don't think 5 years, 2014 to 2019, is enough time for people to fully implement this. So I would like to see providers have 2 more years to fully implement it. So the original deadline for full implementation of 2019 was pushed to 2021. Come early 2020, we found ourselves in the COVID-19 pandemic. And the federal government said, hey, right now people are dealing with so many other issues. At the height of the pandemic, there were something like 4,000 people a day passing away. Plus, so we were all, very concerned. The rules that were coming out, wear a mask, don't wear a mask, wear a mask, isolation, 6 feet, all the other things. If you remember back to those days, were very challenging for all of us. The day services basically suspended, and some providers would then go out to the home and see individuals at home. A lot of providers went to online services, etc. Federal government said, okay, we need to postpone this again. So they then said, we're now going to go to March of 2023. Well, California worked very hard to make the March 2023 rules, and had every provider of home and community-based waiver filled out a self-survey of how they are meeting the rules. And California then certified them and said to the federal government, okay, we have a self-survey from every provider saying that they're meeting the rules. The Fed said, no, we don't accept that. And California ended up getting put on a corrective action plan. So, you think of corrective action plans as a provider. Well, maybe the regional center comes out and says, we're not doing something right, and here's a plan on how to get it corrected by this date or whatever. We don't normally think of the state as being on a corrective action plan, but California was put on, as were many other states. I believe only 1 or 2 states actually met the March 2023 goal of fully implementing home and community-based waiver services. So that is really a reflection on how complex these rules are and how challenging it is to meet all of the guidelines, and for programs to make the shift from the type of services that they were providing to these new services. So as for that corrective plan, California had to go out to every facility and to actually eyeball what was going on at that facility, to review the records, to interview the individuals who attended that program, who lived in that home, and then write a report as to whether that particular program, that particular residential provider was in compliance. If they weren't in compliance, they then got a period of time to correct it. If they didn't correct it within that period of time, it sort of ratcheted up, and people could have potentially lost funding if they didn't come into compliance. Well, lo and behold, by July of 2024, California was able to certify, because all 21 regional centers went out and assessed all of their providers and got them into compliance or had correction plans that were now completed. And so that's when it fully went into place. And a lot of providers went, we're done with this now. We can just go get back on doing business as usual. And no, that's not what's going on. Now, what's happening is the next round, the feds came back and said, okay, so now what are you doing to make sure that facilities are continuing to implement this? So we want to see that you're assessing folks on an ongoing basis, not just the one time that you did in 2023, 2024, but ongoing. So in the near future, if most of you will be involved in some sort of a updated assessment as to the implementation of the home and community-based waiver in your particular program. So the answer to that question is actually all of them. So here we go, another one. What must providers demonstrate to show compliance with the final rule? Okay, high staff to client ratios, community integration and individual autonomy, institutional licensing, and cost effectiveness. Any takers? Like somebody new? Oh, okay. Go ahead, Mark. Hand raised. Okay, go ahead. Did you want to?
Put in the chat. He said the second one.
Okay, second one. Okay. Yeah, that is correct. That community integration and individual autonomy. So we don't want to see high staff to client ratios. We want your client to staff ratios to be consistent with what you're licensed and vendored for. So whatever your program or your residence is vendored by the regional center for staffing, then that's what you want to do. And this last actually since 2016, the state has been working on a new rate model, and they've gone to a standardized statewide rate model. There are some variations depending on geographic area. Obviously, costs are higher in the Bay Area and Los Angeles, San Diego. So there are some variations on that, but basically a standard rate and standard formats, and that's part of the new vendorization process. The state is looking to standardize vendorization, and the rates reflect that. So there are rates for 1 to 8, 1 to 6, 1 to 4, 1 to 3, 1 to 2, 1 to 1, and those have all been calculated by this third-party group that has come in and contracted with California to develop a standardized system. So your staffing ratios need to be consistent with what you're vendored for. Institutional licensing. Well, if you're a residential facility, community care facility, or a site-based day program, you need to be licensed. That's the Department of Social Services Community Care Licensing Department would license you. So you do need a license, but that's not a requirement under the home and community-based waiver per se. So there are day programs that are 100% community-based that are not licensed, that are providing services. They go to the individual's home, pick them up, take them out into the community during the day, and then bring them back to their home. So all of the services take place, hopefully with meaningful activity throughout the day, and those are not licensed. And so there is licensing involved in many cases, but not always. And then cost effectiveness. Well, that is not necessarily a rule in HCBS. HCBS does say it can't cost any more to do community-based services than there are site-based services, but cost effectiveness has always been a part of the regional center system. That for many years, the rules in the Lanterman Act and in Title 17, the regulations used to say cost effective. And then during the 2008 recession, that got changed to least costly alternative. And the difference being, I could sometimes say, well, this one is more expensive, but they do a better job and they'll do it quicker. This other one costs less, but they take a long time and they don't do a very good job. So in the long run, it's going to cost me more to use the less expensive service than it is to just pay for this other. That got taken away. And the only option was least costly alternative. So that is sometimes a challenge for the provision of care. And when people from regional center are looking at the different providers, historically that was something they were supposed to look at. So you have choice. The client saying, I'd rather go to this one, but this one's less expensive. How do you resolve that? But now with the rates being standardized, so if someone is looking at a day service that is a hybrid of both site-based and community-based, and the ratio for that particular provider is 1:6, the rate's going to be the same anywhere in Kern County, unless there's been an exception for individuals or for that particular facility. So that's all changing. So there's a standardization coming down on all of that, and it's mostly in place now. Okay, the next one is which of the following would likely be considered a non-compliant setting, one that doesn't meet the HCBS rules? A group home with regular community outings, a day program located in a strip mall with public access, a locked memory care unit with no community access, an apartment with private leases and tenant rights. Okay, which one is not HCBS compatible? Somebody said C, and you are correct. A group home with regular outings, that is indeed consistent with the home and community-based waiver. Now, one of the things, again, when you're looking at planning outings for the individuals, well, the two things you want to look at is one, make sure that the individuals have say in where those outings are. And if you've got a group of folks and not everybody agrees, maybe this week we go here, next week we go there. And two, that when you're going out in the community, we want to try to make it meaningful. How does this benefit the individual? What are they learning? How are they? Is this helping them to fully integrate into the community, to learn more about things, to be more independent? So if going out to a restaurant, making sure that people understand how to order food, how to pay the bill, to leave a tip, how to act within that setting, etc. Those are all skills that we can that taking someone out of the community can teach, can reinforce, can model. So we want to do that. So, and then the locked memory care unit with no community access, that is not community care license. That would probably be a healthcare license facility, which is a different type of a license, and it would not fall under the home and community-based waiver. The federal government and the state of California would not approve that facility for this program. And then finally, an apartment with private leases and tenant rights, again, very consistent with what we're trying to achieve under a home and community-based waiver. Okay, what is heightened scrutiny review under home and community or based services final rule? A financial audit of Medicaid billing, a review of staff credentials, a process to determine if a setting is presumed institution can meet the HCBS standards, and a background check for service recipients. Alvin says C, and C is correct. Any facility that is presumed to be institutional or next to an institution or is away from the general community can be viewed as, in some cases, an institutional setting and is not necessarily approved under the waiver. So if a facility is locked and and it's not, people can't leave the facility, can't have access to the community, or it's on the grounds of a hospital. So in the past, many years ago, there was a group home that was adjacent to and run by one of the community hospitals here in town. And if under today's rules, that would have to be looked at very carefully to see if it met the heightened scrutiny rule. Locally, I only believe there were only a couple of facilities that fell under that, and those we were able to resolve. Okay. Which of the following best describes community integration under the final rule? Occasional field trips, living in a gated community, full access to community services and activities, and watching community events on TV. And so 2 people said C. All right, that is correct. What's that? All right, yes, it's the occasional field trips. No, that's the old model. Years ago, that was pretty much most, let's say, for example, day programs and residential facilities stayed at their site. So people got up, they stayed, on the weekends, they would stay at the group home the whole weekend. Rarely would go out, or if they did, maybe they would go out with the provider to a church on Sunday, or of the provider's choosing. And that was very limited. So that's one of the things that we really want to get away from, so that we don't want just the occasional field trip. We want regularly planned outings that are meaningful, that are the person's choosing. Living in a gated community, this is an interesting phenomenon here, because we say that congregating a large group of persons who are intellectually developmentally disabled is a type of segregation. And yet we do have services to the elderly that are congregate communities, communities that are for residents 55 and older. So you have to be that age to be able to live in that community. Senior centers, which are specifically addressing the needs. And we, some people say, well, why can't you have communities for people with intellectual disabilities, just like you have communities for seniors? And the issue becomes one of intentionality. If I'm over 55 and I share with you that I want to live only with people over 55. Hey, I paid my dues. I had my kids. I got my grandkids or whatever. I want to be with other people, similar interests, similar needs, in a center where I can relate to other people living there, don't have the disturbances of children and what have you. I could have that option. Or I want to go to a program. So that's an option that people decided for themselves. Historically, the view has been that persons with developmental disabilities had not been given that option. When they were living in these segregated communities, that was because that's what was available. and they were placed there because that was where the services were being provided, and not because they made the choice to live there. So that's why it's been not been viewed as an alternative or choice for the most part. There has been some pushback. Some groups want to create communities specifically for people with intellectual and developmental disabilities, and there are issues related to that. Some of them have maybe decided that they just won't take home and community-based funding, etc. So that is still a controversy in a way. And then watching community events on TV, no, that's we all, unfortunately, I watch the evening news, and it's usually not that positive. I wish that we had more positive events being reported on. I'm sure they're out there, and we just need to sort of change our focus sometimes, I think. All right. Next. Okay, so we're a true or false again. Okay, individuals receiving home and community-based residential care must be given a lease or residential agreement compatible to those of the broader community. True or false? Okay, one person says false, another person says false, somebody says true. It is true that the people who live in residential facilities must have a residential agreement. Now, historically, there is an admissions agreement that is signed when somebody first moves into a residential care facility. Now, licensing has required that for as long as I've been in the system. So it goes back into the 1970s. And the admissions agreement has changed over the years, and it's gotten bigger and more pages and what have you. And at this point in time, regional centers are accepting that. So if you have an admissions agreement for people who live in your residential facility as the lease or community agreement for the individuals that live in the home. But just like a lease agreement in the community, there are protections against eviction. There is something in there that the resident's supposed to give notice if they want to leave. Although, if someone wants to leave, they can leave. But then the facility and the regional center then look at how they settle up in terms of the payment. But the home and community-based waiver services say that there has to be a agreement that spells out the living arrangement for that individual in that setting. And like I say, now, Leslie, I know you're still on. At one point, the community services folks were looking at developing a statewide agreement that could be used for everyone. Do you know if anything's happened with that?
So I haven't heard about it being implemented just yet. I know that there was in Southern California a group that was putting together a standardized admissions agreement that the regional center system could use. I haven't heard just yet, but
Okay.
As best practice, we always encourage our vendors in our residential to create their own admissions agreement. We call it now residency agreement, which is more appropriate, to include those areas that support the tenant's rights around the evictions process, as well as adding additional areas like such as including like the other HCBS rules for like privacy, supporting how each individual has a lockable bedroom door with key access, and adding other areas that could support how your services deliver those rights. And so we always encourage that. That is within our provider's ability to control at this time.
Okay. So if someone is using the KRC admissions agreement, what you're saying is adding on to that, to things that are specific to their facility. like an addendum to it as well, is something that you would encourage. Okay. What does the final rule require regarding staff interaction with individuals? So how are you supposed to interact with the people that you're providing services to? Staff must make decisions for individuals, so it's your job to make the decisions for people. Staff must provide constant supervision. Staff must support autonomy and respect choices, and staff must enforce facility rules. Okay, so most of the people who responded said C, and that is correct. Staff must support autonomy and respect choices. Okay, staff must make individuals for decisions. Must make decisions for individuals. No, they're obviously if somebody is in a situation where they're about to jeopardize their safety, you want to intervene and protect somebody so that they're not hurt or damaged if you're available. Constant supervision is licensing does require you to provide supervision for individuals, but in nowadays, if the individual plan for that individual, that person-centered plan, specifically has times when that individual is going out in the community on their own, doing activities independently, that can be written into the plan and allowed for the individuals so that there doesn't need to be supervision at all times, that people can utilize the community if it's written into their plan independently and still live in a licensed facility, still go to a licensed day program during that time, but they can be out and about if that's what their individual plan reflects for that individual. And you want to make sure that it's in the plan, because that way it shows that it was done as part of the planning process, and that it also, if something happens, shows that this was the individual's choice to be out and about. And then staff must enforce facility rules. The ability to have facility rules and to enforce them have been somewhat limited under the home and community-based waiver. You need to make sure that any rules that you have are respecting the client's privacy, dignity, ability to make choices. I've gone out to facilities and there be a house rule that everybody lights out at 10 o'clock, or no alcohol, or other things that we then have to talk with that provider about, okay, so how are these compliant with the home and community-based waiver, and what are other things that we can do to address the particular concern that you have in this given area. Okay. Which of the following is a person-centered planning requirement under the final rule? Okay. One size fits all service plans. Plans developed solely by providers. Plans based on individual strengths, preferences, and goals. And plans focusing on cost efficiency. Okay, I see C coming up, and that is correct. That the plans are based on the individual strengths, preferences, and goals. And this is a very big change that we evolved to over the years. That many years ago, when I first started in this system, we had what was called the problem-oriented record. And what we did was we focused on the person's problems. What were they not doing right? What were their deficiencies? What did we need to correct? And so we'd write a plan like that the client couldn't live on their own, so we wanted to have we wanted to get them in a residential care home to protect them and to make them safe, and, because of their inability to live independent or to live otherwise, or that they had nothing to do during the day. So we want to get them into a program so that they have something to do. So those things have changed over the years to reflect. Now we look at, okay, what does this person do well? What are their preferences and what are their goals? And what we find is that we're actually able to teach, to learn, to be able to accomplish greater things if we look at what we know, and what is our strength. And so that's really the direction that we want to go. And as you have noticed, if you're sitting on the plans that are being written for individuals, in many cases, the vendor or sometimes the regional center staff will come in with a one-page sheet, which is sort of a biography of the person. It's got a picture of the individual, and it talks about what they like doing, what they like, what their wants are, what their hopes are, what their dreams are. And the plan wants to really focus on that. So when we're talking about the services that they're receiving in your residential home, the services that they're receiving in the day service that they're attending, that they're reflective of that individual strengths, their preferences, their goals. Years ago, I was involved with an organization that had a sheltered workshop. And there was an individual who was attending who, if you looked at their cognitive ability, so if you looked at their IQ on a test, this person was functioning in a moderate level of disability. And what you had seen, based off the paper, is limited abilities in a number of areas. This individual grew up in a home where all of his family members worked, and he was exposed to that as a child. He was brought out to the field as a child and assisted with the work that his family was doing. And so as an adult, he had really good work skills in a specific area, and was highly productive. And so if we would have focused on what it said on the paper, we would have gotten very, very different results for this individual than what he was able to achieve, and what we were able to provide him programming for, based on looking at what his strengths were and what he liked doing. So those became his goals, and he actually was very successful in the particular work setting that he was in. And the focus on cost effectiveness. Again, we want to be cost effective. That's what we need to do that. And in the coming years, as we see some of the major cutbacks to Medicaid funding, the need to be cost effective will be even more critical. That we'll really need to look at how we provide services and where, and then also what services are available to people, and those may be changing. This morning I was reading the Bakersfield, California, our local newspaper, and there was an article in there about how the city is looking at the potential cutbacks that they may be looking at because of the new federal budget, and they don't really know. It's just a question mark at this point. So over the next couple of years, how much less federal money might be flowing into Bakersfield so to help run the government. So the same sort of thing is over the next few years, how much less money might be flowing into DDS and to California, so that monies that will come down to the regional center that will then come down to you as a provider, what will that be in a few years? And that's a big question mark. None of us really know for sure. I know there are a lot of people predicting, and I think that we can be reasonably assured that there will be cutbacks. But how much and where those will occur, I don't have a crystal ball. Okay. what is significant? What is the significance of individual initiative in the final rule? It refers to provider-led activities, these activities that you do. It ensures individuals can make choices about their own lives. It limits community access, and it applies only to employment settings. Any takers on that? Okay, somebody said B. Any others?
Individual can make
Yeah,
choices.
B. Okay, everybody's going B on that one, and that one, that is correct. It ensures individuals can make choices about their own lives, and that's what we really want to see. We want to see that the people that we are working with are we want them to be over here on the gas meter on the smile side, not at the empty side, and we don't want providers leading the activities when we can avoid it. We want to try to give people more choices about what they do, and to be the participants. And we don't want to limit community access. We want to give people as much community access as they prefer, and to try to give them enjoyable activities. A lot of times with community access, is one of the things that some of you have heard me say this in the past. When I was working for Bakersfield ARC, and we really started our community-based programs, we sort of went to the individuals that were being served, and we said, okay, we want to start doing more stuff in the community. Where would you like to go? And many of the respondents, many of the people who were participants in our program, said that we'd like to go to Walmart, to Dollar Tree, to the Valley Plaza, and maybe movie theater, maybe bowling, and that's what they knew. So when asking people what choices they would like, part of what we really want to try to do as well is to expose them to new opportunities. And so when we say to provider-led activities, and we don't want to be leading the activity, but it doesn't mean that you as the direct support professional, you as the administrator, can't make suggestions on alternatives for people. Well, I don't like that. I'm scared of that. I've never done that before. It's not something I know anything about. Well, let's try it. Let's see if you what happens if we go for that hike out at Wind Wolf one day, or we spend an afternoon at a picnicking out at Hart Park, or just all kinds of different things. Let's go out to Riverwalk and go to some of the stores there, and let's talk to the managers about what it takes to work here, or look to see what they what products they sell at this particular store, so we have some idea of what the people are doing in the community. Hang on just one sec. Margot, I was thinking about going to Costco after this. Do you anything you need? What? I was thinking about going to Costco after this.
You're not muted, Jeff.
Okay. Oops.
Thank you for everybody that is actively participating. Greatly appreciate that.
Jeff sorry about that.
Answer his own questions earlier, so we appreciate it.
My wife was just leaving, and I wanted to ask her something really quick. I'm sorry. So, okay, moving on to the next slide. We're getting close to the completing here. Which of the following centers or settings might trigger a heightened scrutiny review? So that extra review to make sure that you're not an institution. A private apartment with lease protections, a setting on the grounds of a nursing facility, a community-based day program, or a home with individual supports. Which one do you think would might trigger an extra review? Any takers? Okay, D maybe. Actually, it is a couple people said the home of individual supports. No, a setting on the grounds of a nursing facility, because again, that's an institution. So if there's an institution involved, yeah, B would be the right answer. So if there's an institution involved or a medical facility, and then there's a group home that's part of that, then it gets looked at differently because it's really not considered to be a community-based facility. We want facilities that are sort of standalone, that are out in the community. Earlier on, there was one that talked about a storefront in a strip mall, where so the clients would have their day program would take place in basically a small shopping center. Well, that's in the community, right? People are coming and going to the shopping center. It's probably on street, and there maybe there's buses that go there. People can get to and from there, transportation. They can there are places maybe they can eat nearby. There are other things. That's really what you want to do. A setting that's at a nursing facility is considered to be more restrictive. We want to try to not move away from that. And then true or false, the final rule prohibits all congregate settings. No, so that's a tough one. Okay, no, the answer is false. It's here you have people in a sheltered employment doing piecework. Now that setting would be restricted under the home and community-based facility. But if you go out, there are still many adult day programs, especially, and also residential facilities, which are just the individuals that we serve. And just because it's a congregate setting doesn't mean that they're not going out into the community and doing things that are that have to do with the community. So what we really are trying to encourage for those settings that are congregate is to be a hybrid. How do you get out and do things in the community, plan alternative actions? If it's a program during the day, how many days a week are you going to be out in the community doing the day services at your prescribed ratio somewhere other than at your setting? So that's what we really want to try to encourage. Okay, we have 3 more questions, and so we're getting right to the end here. What must be documented in a person-centered plan to meet the final rule standards? The provider's preferred schedule, so what schedule you want to make for the clients, the individual's goals, preferences, and risks, the facility's rules and expectations, or the state funding limits. Okay, somebody said B, another B, another B. Yeah, it is B indeed. The individual
goals, preferences, and risks.
Yeah. The provider's preferred schedule. Years ago, again, I some people refer to me as a historian because I've been around for a long time, and I sort of have seen the many changes. If an individual was moving into a group home, or an individual was going to a program and they were new, the provider would sit down and basically tell the individual, this is our schedule. This is so if you live here, we all get up at 6:30. We have breakfast. You get groomed. You get ready. The bus comes at 7:15. You program. In the evening when you get back, this is rest time. This is that. Weekends we do. And there was a whole laid out schedule for everybody. The same thing for the day programs. From 8 to 9, we assemble, and all the buses come in. From 9 to 10, we do. Personal hygiene skills. From 10 to 11, we watch a movie. From 12 o'clock, we have lunch, and then 2:30 you go home. And that was a schedule based on the provider's needs. And somebody coming to the program, if they said, well, no, I don't want to do that from 10 to 11, there wasn't a choice. if you're coming here, this is what we do from 10 to 11. And that was one of the things that home and community-based waiver services really tried to change. Facility rules and expectations. Again, you can have rules and expectations, but they have to be consistent with the client's dignity, privacy, respect, and consistent with the home and community-based rules. State funding limits. California is an entitlement. If it's written into the plan that the individual gets those services, what's going to happen over the next 10 years with the changes at the federal level, with the cuts to Medicaid? Will California do like many other states, which do limit services? If any of you read my newsletter that goes out under the BARC heading at the beginning of the month, this month there was an article about West Virginia and the limited number of people who are on the home and community-based waiver services. And they've got like a couple hundred people on their home and community-based waiver, and over 750 people waiting to get on the waiver, and many more out there that are still even on a waiting list. And so states can limit funding, and the federal government signs a contract with the state. State says, we want to provide this many individuals with services. Fed and the federal government and the state negotiate. They decide, they agree on a number of persons that can be served. Then they look at what services the state wants to provide. The state submits a list. The federal government negotiates with the state. They agree on what services that the state can provide under this program, and then that's how it goes. If later on the state wants to go back and renegotiate the services that they provide, or the feds come in and say, okay, we're going to provide less money, then it needs to be relooked at. And that's what we may be looking at in the future. Which of the following is a key principle to the HCBS rules? Institutional efficiency, uniformity of service, individual choice and control, or centralized decision making. Okay, I see C coming up by people, and that's correct. Individual choice and control. We're not about individual efficiency, although if you are a provider of services and you can be efficient, it's almost a given that the funding that's available to run our programs, the purchase of service dollars that we receive, what we're vendorized for, our daily rate or hourly rate, however we're set up, really doesn't cover the cost of services. And with the continuing inflation and things costing more, it gets harder and harder to provide the services that we do. Some programs have closed. Some others have said we can't take anybody additional because of staffing issues. It's hard to find people who work here for what we're able to pay. Other things. So institutional efficiency is always important. You always want to, but that's not a key principle of the waiver. Uniformity of services. Again, if we're looking at providing services to the individual, we want to try to get away from uniformity. Although, again, cost effectiveness would have us look to uniformity, because if we can do it one way, that it makes it less expensive. But that's not consistent with the home and community-based waiver in terms of what they are requiring. And then centralized decision making. As a provider of care, you may want to look to your facility at who makes the decisions, how they're going to be trickled down to the managers of your program, the direct care staff, etc. But those need to be consistent with the federal home and community-based waiver requirements. Okay, and this is our last slide for today. It's just about 11:30, so we're right on time. Okay, what is the role of California in implementing the home and community-based final rule? Okay, what are we doing here in California to implement the federal rule? To monitor compliance and to submit transition plans to CMS, to eliminate all group homes, to reduce Medicaid enrollment, and to centralize service delivery. And I saw one person said A. Any other takers on that? Well, yeah, that's the correct answer. To monitor compliance and submit transition plans to the Center for Medicaid Services. So, as California, as I mentioned earlier, you all are going to be reassessed and probably reassessed on an ongoing basis as to making sure that you are indeed following the rules. There is no movement to eliminate all group homes. That's not even anywhere on the map. To reduce Medicaid enrollment, the big, beautiful bill, the one that was just signed by the federal government, does have goals to reduce Medicaid and who is eligible for it. The folks behind the bill have said specifically that there is no attempt to really eliminate the Medicaid services for those who are truly needy, and so that Medicaid and SSI and those services should continue to be eligible for the people that we serve. However, if states find themselves in a position where they have to eliminate some of the home and community-based services, which are optional services, we may indeed see some changes, either minor or could be major, we don't know, to what we do in the future for the people that we serve. And finally, we want to move away from centralized services because centralized services tend to be segregated, and we want to integrate our services and be out in the community. Okay, that will be it for today. Any questions, concerns, comments you'd like to make before we end today's session? You can open your mic and speak up if you want. Okay, so as Valerie just put up there, if you want if you were here for the whole session and you want the CEUs, send those 3 things that you learned today to Irene at Bakersfield ARC, and we will get you a certificate for an hour-and-a-half training. Any other comments or questions, concerns? Well, thank you. Hope you have a good day. Hope this is interesting. Now, Leslie, before we go, you're still on there. There's some other trainings coming up. Another group, Beyond Compliance, is going to be doing training in December. You want to share something really quick?
Yes, absolutely. So we have another training coming up with a consultant called Beyond Compliance. They will be coming to the Regional Center on December 11th in person to present in the Malibu Room on the topic of meaningful and measurable outcomes and objectives. So it's a really great training for those that are involved in the planning process, that take part in making goals for our individuals that are meaningful to them. So it's really great training for those that are interested. It will be shared with Bakersfield ARC to share out to you folks. That way you guys could receive an email of the invite and how to register. We also have that training presented the following week again on Zoom for those that are more interested on doing Zoom calls. So that will be held on Wednesday, December 17th in the morning from 9 to 12 a.m. And so thank you guys again for your participation on this community of practice hour. So these hours are for you guys to ask questions too. So always feel free to ask and share a little bit and ask for more information on things that you hear.
Yeah, that good point, Leslie. You've got Leslie's an expert. She's the state liaison from Kern Regional Center on this program. I'm an independent consultant with 48 years experience. We also have Valerie on this call, who's been working at Bakersfield ARC, who's got a lot of experience in this area. So you have experts available to you. So this is the time you can ask. Also, you can get a hold of us if you want to contact Valerie through Bakersfield ARC or Leslie through KRC. If you want to just ask it personally, go ahead and do that, and they can get a hold of me as well. So, and if you want to get a hold of me directly, if you just type in my name, Jeffrey Popkin at gmail.com, you can also get a hold of me. All right, with that, we will end the session today and look forward to seeing you again next month. Bye now.
Thank you, Jeff. And you did get some compliments of your interactive
I saw that.
today.
Yeah, it's good. I think it was a good format. I think it worked out well.
It was awesome. Thank you. Hope to see you all next month.